Learning OMM is a lot like learning a completely different language. You have to learn the vocabulary first so that you can understand everything that's to come later on. The way that this course is laid out is in a very particular order. So if you watch it in that order, all of the topics, concepts, and language that we use is introduced throughout so that at the end it all makes sense. For you to do well in this course, not only do you need to understand the information that I give you, but you also need to be able to learn the concepts and be able to apply the concepts to different situations. When you take an exam, you're going to see information that you haven't seen before. And what the exam writer is wanting to do is to see if you know the concepts. So in this lecture, we're going to go over some of the basic vocabulary that you're going to use for the rest of the course. So to start off with, what is a dysfunction? A dysfunction is basically an abnormal function of normal anatomy. So what you can and cannot do. So an example of this would be, normally I can flex my arm all the way in, I can extend my arm all the way out. If I cannot bring my arm all the way into flexion, that's what we would call a somatic dysfunction. So abnormal function of anatomy. So how do we name a dysfunction? How do we know between each practitioner what we're talking about? What you need to do is you need to name the dysfunction for what the segment can do. It sounds confusing because you want to say that the arm cannot flex, so you think that you want to say can't flex. In reality, what you say is the patient has a extension dysfunction, which means that they can extend and they cannot flex. So you always name it by what it can do. So how do I find some of these dysfunctions? What are some of the palpatory findings that I'm going to see? This is what classifies as a TART change. And TART stands for texture, asymmetry, restriction, and tenderness. And depending on if the dysfunction is acute or chronic, you're going to have different findings for each section. If you have an acute dysfunction and you're palpating the tissues, you're going to feel hot tissues, or boggy, or even moist. So think about it as being brand new. It's still red hot. So the dysfunctional palpatory findings will be hot, boggy, moist when you palpate the skin. When you do your palpation, you're also going to feel asymmetry. So one side is not going to feel the same way that the other side will feel. It'll feel asymmetric. For restriction, we're really talking about pain on motion. So since it's brand new, it's an acute dysfunction, you can imagine that there's going to be a lot of pain on movement. So let's say that the patient just hurt their back and they just got a spine somatic dysfunction. When they bend forward or try and rotate, it may be very painful. And this is telling you that it's an acute dysfunction. For tenderness, they're doing the quality of the pain. So if it's acute, the pain will be intense or sharp. So if I take my thumb and I jam it, whatever muscle is dysfunctional, it's going to feel intense, it's going to feel sharp. So if on an exam you have any of these findings, the exam writer is trying to tell you that it's an acute dysfunction. And then we're going to compare that to chronic. Chronic or ongoing dysfunction is going to have palpatory findings that are basically the opposite of acute. So you're going to feel cool tissues, or they're going to be ropey tissues, or they'll be dry tissues. When you're feeling for symmetry, you're still going to palpate asymmetry. So that's going to be the same for acute and for chronic. If it's a chronic dysfunction, it's been lingering a little while. The rest of your body is starting to compensate. So it may have decreased pain on motion, or even no pain on motion at all. And if it's been sitting around a while, it's not going to be nearly as intense or nearly as sharp as it was when it first occurred. So it's going to be more of an achy pain or a dull pain. So when you jam your thumb into it, it feels more achy or it feels more dull. So there are three primary motions that occur in every segment. You can have flexion, which is bending forward or anteriorly. You can have extension, which is bending back posteriorly. You can have rotation, which is turning your body. And you can have side bending, which is moving your body to the left and to the right like this. Each of these motions occur in a plane and around an axis. So to label the planes of motion, we're going to use some pictures. So a plane of motion, you can almost imagine it as if the body is being cut directly in that motion and you're getting two equal slices on each side. So for a sagittal plane, it's a plane that cuts right along the bridge of the nose and goes directly down the rest of the body. So you're going to be split right down the middle like this. For a transverse plane, it's going to go from ear to ear. It's going to go horizontally. So a transverse plane would be if I get a cut right here and I can separate the top half and the lower half of my body into two completely different segments. So the last plane is the coronal plane. Now this plane, imagine if you're wearing a crown for your coronal plane and it cuts directly down the middle. So it'll be a slice just right here and it will fold out your body like this. So next there are three axes of motion. You can have a horizontal axis, which is a singular line that goes through the body. So imagine if I take the pin, push it through my body, that's the axis. You're not cutting the entire body, it's a singular point. So a horizontal axis goes from hip to hip. A vertical axis goes from the top of the body all the way down to the bottom. So if I take the same pin through the head, out the feet, that's a vertical axis. And finally, you have an AP axis, or an anterior-posterior axis. It goes directly from the anterior side to the posterior side, so if I push directly towards me. Now each of these axes can be moved slightly around the body depending on where you want to be turning. So the AP axis can be located in the center, it can be located around the neck, on the hand, wherever. But wherever the axis is, the rest of the rotational component will occur around that axis. So now to talk about flexion, extension, and side bending. So each of these motions will occur on a plane and around an axis. So the easiest way to think about this would be think about an umbrella. An umbrella has a handle and it also has a gigantic upper part that protects you from the rain. If you're twisting the handle around, the top part will spin around as well. If you imagine the handle of the umbrella is the axis, and the umbrella itself is the plane, and that gives you an idea of how the planes of motion actually work around each axis. So if we're talking about flexion and extension, you need to relate that to the umbrella. The easiest way would be to stick one of your arms out and then flex and extend. And when I'm making that motion, I'm drawing the plane with my arm going around. And that plane is going to be a sagittal plane. Now with that same analogy, imagine that I'm taking an axis and going 90 degrees at the plane, which means that it will go directly through my hips. So if I take that umbrella handle and twist it, I'm flexing forward and I am extending backwards. So the plane that flexion and extension occurs on is the sagittal plane, and the axis that it goes around is horizontal. Now for rotation, it's the same umbrella idea. If I stick my arms out and I rotate, I'm drawing the transverse plane with my arms. If I'm wanting to do the rotation on the umbrella stick, I'm twisting my body around it. So it's going to be the vertical axis. And for side bending, the same idea. If I stick my arm out and I side bend, I can draw the plane with my arm. That plane that I'm drawing is the coronal plane, and the 90-degree axis is going to be the AP axis. So now that you understand the axes and planes of each motion, you need to understand the barriers, and you need to learn the vocabulary for barriers. So to do this, we are going to look at a single vertebral unit. So there are a few different barriers that you need to learn the names of. The first one is neutral. So in neutral, the patient is totally relaxed. They're sitting still. This is how the anatomy normally sits in neutral. So relaxed. The next barrier is going to be the physiologic barrier. Now if I'm going to take my vertebral segment and rotate around this axis, and I get to the P, that's the physiologic barrier. Now physiologic is the range of motion that the patient has during active movement. So if I am actively trying to rotate my head to the right, and that's as far as I can go, that's the physiologic barrier. So active motion. The next barrier that you're going to hit is the anatomic barrier. Now, if the practitioner comes in and they decide that they're going to rotate my head, they can probably move my head more into rotation than I would be on my own. So that passive motion is going to reach a further barrier. That's the anatomic barrier. Now the final barrier that you need to understand is the restrictive barrier. So the restrictive barrier is some sort of abnormal barrier, a barrier where you shouldn't be stuck at. So if I'm rotating this vertebral segment all the way down to the left, so if I'm rotating to the left, I should be able to passively move the segment all the way to the anatomic barrier. But if I get stuck here and I can only rotate a little bit, that's the restrictive barrier. Now once again, they're not able to rotate all the way to the restrictive barrier. This is confusing because of how you want to name the diagnosis. Remember, you always want to name it based off what it can do. So it seems backwards because you want to say it's stuck, rotated in this direction. In reality, you want to say what it can do. So it can rotate the other direction normally, and that's what you would name it on. So the last thing that you need to understand is the types of muscle contractions. And there are two types of isotonic muscle contractions. You have concentric and eccentric. Now, concentric muscle contraction is when the patient actively contracts their muscle. it brings the origin and the insertion closer together. So if I am concentrically contracting my bicep, I'm bringing my arm further this direction. So one way to think about it would be you're at the gym, you're doing your positives for your gains, you're bringing your arm up, that's a concentric motion. An eccentric contraction is a lengthening of the muscle while the patient is still contracting the muscle. Easy way to think about eccentric contraction is if you're still in the gym, you're doing your negatives. So you've already flexed up, you have the weight, you're still contracting the muscle, but you're slowly elongating the muscle. This elongation is eccentric. The next type of muscle contraction is isolytic. Isolytic is where an outside force breaks the patient's muscle contraction 100%. So the easiest way to think about this would be if you are arm wrestling someone who is bigger than you. When you're arm wrestling, you're holding it steady, but eventually their strength overtakes you and you let it go. That is isolytic. It's breaking your muscle contraction. And the final muscle contraction type is isometric. Isometric is the most important muscle contraction for osteopathy. This is the type of muscle contraction that we're going for during most of our treatments. So isometric means that the amount of contraction that the patient is exhibiting is the same amount of contraction that the practitioner is exhibiting. So both forces cancel each other out. So even though I'm pushing, I'm not elongating and I'm not shortening the muscle group. So that's isometric. So this is the vocabulary that you're going to need to continue with the rest of the course. We started off with what is a dysfunction, how do you name the dysfunction, TART changes for acute and chronic dysfunctions, planes of motion, axes of motion with our umbrella, the specific barriers including neutral, physiologic, anatomic, and restrictive, and different types of muscle contractions. And that's the introduction for OMM.